Okay, everybody, I think we'll get going. So welcome to our webinar, which is titled Reflections on Culture Change, which a number of members of staff of Coventry HDRC are going to present on. A couple of really quick housekeeping reminders to go through. Session is being recorded, so please remember to keep your microphone off. We're scheduled to run until around about 3 o'clock, and we've got about 10-15 minutes dedicated to questions at the end of that time. If you are asking a question, please pop your hand up. It would be great to see you if you're able to put your camera on for that, or put something in the chat and we'll get to those questions as well. The slides from today will be emailed out after the presentation, along with the recording and an evaluation form. And it's really helpful to get some feedback on those. It really helps us as we're developing our offer from the Specialist Centre. So we'd be very grateful if you could fill that in and return it. So on to our speakers. John Wilcox is the head of Coventry HDRC, and he's responsible for the programme and team management, planning, implementation and governance. He was previously a senior public health manager and has over 20 years experience in multi-agency public health across health promotion, research, evaluation in local government, the NHS and universities. We have Dr. Jenny Harlock, who is an associate professor at the University of Warwick with a background in health and social care research. Jenny is also an NIHR Research Support Service Public Involvement Advisor, and she's currently on secondment with Coventry Council, supporting research on health and homelessness through the HDRC. And we have Chloe Ryder, who is a research fellow in quantitative and mixed methods. Chloe's developing the data catalogue and is involved in a research bid application, developing training, designing mixed methods service evaluations, and alongside being an HDRC research fellow, she's a trainee health psychologist at the University of Staffordshire. So I'll pass on to the Coventry team now, and John's going to start.
Thanks, Nicola. So yeah, welcome everybody. So as Nicola said, we're going to each tell you a little bit about what we've been doing in Coventry HDRC. So I'm going to start off giving you an introduction, and then Jenny's going to give an example of work that we've been doing around health and homelessness. And then finally, Chloe's going to talk about a piece of work around data that we've been doing. And then there's an opportunity to ask us any questions at the end. So yeah, first of all, I'm going to tell you a little bit about what Coventry HDRC is and what we think some of the successes and challenges have been. So first of all, a little bit about Coventry. So for those that don't know, Coventry is an area within the West Midlands of England, and the local authority is Coventry City Council, which is a unitary authority, which is also part of the West Midlands Combined Authority. Coventry's got a current estimated population of around 361,000 people. It's a relatively young population with a medium age around 5 years below the regional and national average. And Coventry is also a very diverse city, with 45% of residents being part of an ethnic group other than white British, which is up from around a third in 2011. Coventry's got a long history of partnership working to tackle inequalities in the social determinants of health, and a decade ago Coventry was the first place in the UK to become a Marmot City, which is now a national programme working with the Institute of Health Equity at UCL. So Coventry's HDRC very much built on the work that had already been done in the city around tackling health inequalities, and that was really the foundation of what we do. So before we go on to that, I'll tell you a little bit about the HDRC programme for those that are a little bit less familiar. So pre-pandemic, NIHR were looking into doing more public health research and really wanted the funding around research to be impactful. As I understand, around 90% of NIHR's funding goes into healthcare research. So then post-pandemic, NIHR launched the ability for local authorities to apply for the Health Determinants Research Collaboration Programme, and Coventry was one of the applicants in the first round, and then subsequently was successful as one of 10 local authorities. So the NIHR programme is really about developing capacity and capability around public health research within local authorities, and there's a particular emphasis with it being based within local authorities to look at, can we do more research around the wider determinants of health? And the whole programme, which is now 30 local authorities in England, Scotland and Wales, is really trying to change the culture. So we know obviously there's excellent pockets of evidence-based practice within local authorities already, and it's really trying to build on that and add value so that there's a link between academic research and evidence-based practice, and we can really start to develop research ecosystems around local government and place, which has got that focus on inequalities in the wider determinants of health and the pathway to health inequalities, so that research can have more of a route to impact, and we can, using some of the other buzzwords, I guess, look at knowledge mobilisation. How can we really use the knowledge that emanates from research alongside different forms of knowledge? And now that programme has been going for a couple of years. So in Coventry, we're in just the beginning of year 4 of 5, and we were in the first wave. Those who are in the second wave of HDRCs are going into probably end of year 2. So now there's 30 HDRCs plus alongside the other NIHR public health research programs nationally, and there's starting to be a good critical mass of research capacity around public health in the UK. So within Coventry HDRC, all HDRCs are a partnership between one or more universities and the local government. They're all place-based, and within Coventry, our Health Determinants Research Collaboration is between Coventry City Council, the University of Warwick, Coventry University, some input from the NHS, from the local teaching hospital, UHCW. In addition, importantly, we've got input from the voluntary and community sector, so really getting that third sector input into this. And a really important thing for HDRCs is the ability to really bring the public voice into research along the research pipeline. So be that using existing research, be that generating new research and knowledge, how can we make sure the lived experience is part of that? So public involvement is a really important part of what we do. And then within Coventry, we're structured around what we call 5 pillars, which are listed there. So each of these pillars has got a university lead and a council lead, so that there's that shared accountability and leadership within our collaboration. So as I've said, this is around research, but we also appreciate that research is just one form of knowledge, and it sits alongside other forms of knowledge that people already use in that local authority environment. So we're looking to bring in the academic research to inform practice and evidence-based practice, but it's also, as I've said, really important we think about lived experience and that we value professional knowledge. We utilise the data that's available within local authorities, be that new data that's derived from evaluation, the organisational data that's collected by service, or population health data that's collected around the population its needs. And it's really, as we've depicted in this, it's like a bit of a jigsaw, how we bring together these pieces to make a difference. So all HDRCs use a large portion of their funding to create a team within the local authority. So this is pictures of our core team, which you can look on our website, the Coventry HDRC website. And within our team, we've got skills around research. We've got skills around public involvement, around research governance, around program management, around communication. And as I said, alongside that, each of our pillars, 5 pillars, has got a university lead. So some of our funding goes from NIHR to the local authority and out to the universities to fund academic leadership around our pillars, and also voluntary sector involvement. And we also use some of the funding for public involvement, as well as some of the interventions to develop capacity and capability around our 5 pillars. So thinking about some of our successes and reflecting on that to date, as I say, we've been going 3 years. So Coventry had what I've described, there was 0 when we started. So a big part of the first year was really setting up the team, recruiting the team and getting things going. And then as we've gone into years 2 and 3, we've started to implement some of our key programs. So some of those, for example, now we've got a research governance process built by the collaboration for the local authority and for the collaboration. And in that, we've also got a research ethics process, which is just starting as well. And both of those have got public involvement and representation from diverse groups across the City Council as well. Developing training and skills is really important. So if you look on our website and related YouTube channel, we've got a plethora of webinars that we've done around different skills and methods and learning around public health and related research. We've worked with Coventry University to develop a citizen science training programme. And we've got a public voice group. So it's really important that we continue and strive to get involvement from representative of Coventry's diverse population and look at how we can offer opportunities for them to be involved in research. We've got a research ambassador program. So this is really local people who work in the voluntary sector and people who work in the City Council, who then we're using some of the funding for them to operate as knowledge brokers within the HDRC. And we've got an emerging research pipeline. So obviously one of the functions of the HDRC, once we get all of this infrastructure in place, going into years 4 and 5 of this round of funding, is to ensure that we can use it to generate new research which meet the research interests and our research priorities, so that then that pipeline can then inform practice. And because we're a new collaboration, we've got a big portion of our funding dedicated to evaluation. So you saw that one of our pillars is evaluation. So we're evaluating the strength of our collaboration, and we're feeding that evaluation back into our program management in a sort of learning perspective. So some of the learning to date has been to reflect on is that, as with any collaboration, and I think if you look at the evidence base around research collaboration, you can't underestimate the time, energy and resource it needs to invest in those relationships, because universities and local authorities don't naturally work together except where there's like a vested interest on particular research funding or something like that. So a lot of our time and energy is developing those relationships with internal stakeholders and in the voluntary sector with communities and within the universities, and trying to bring that all together in different ways. One of the things that I've been working with the Public Health Research Support Service that they've led on nationally is thinking about the terminology we use. Research and the word around academic research can be quite off-putting and loaded. So we do quite carefully think about how we use that terminology, how we use technical terminology like wide determinants of health, etc. like any big program, when you work in an organisation, some of our initiatives have been delayed due to approvals processes. So one of the important things is really to plan those things out and have contingency plans if things are taking longer than necessary. Be clear on priorities and what they mean. So this infographic that we've got, we use the building blocks of health analogy to explain to people less informed around public health what we mean by these factors which contribute to people's health. And these are our current priorities that we're developing our research interest, in particular research initiatives and projects around. But we're not completely wedded to them. We do look at other emerging priorities, but being clear on them and communicating them is really important, we've found. Having that capacity for meaningful public involvement, and again, similar to what I talked about, collaboration relationships, as with any volunteering programme where we want to appreciate and thank people for their time. We want it to be meaningful, and we're basically adhering to the NIHR guidelines around public involvement. And some of the other things, I guess, is using good change management principles. So really thinking about, this is a culture change. So as with any organisational change, not everyone is going to think it's the best thing since sliced bread. You've really got to think about how, when we're trying to change culture and trying to change processes, in this case around evidence-based practice, better use of research, how we bring everyone along, those people who are less engaged than others, and really think about that change management process. And as I said when I was talking about the evidence jigsaw, it's really important to appreciate, we've found that to value the professional knowledge and the fact that people already used evidence-based practice to a certain extent, and we're really adding to that. And finally, the ongoing communication is important. So developing research in a new setting, again, is a new initiative around local government and doing it at scale. So it's really important to continue to communicate what you're doing, but also the benefits of that, because there'll be a lot of competing priorities. So yeah, that's a bit of a quick run through of what the HDRC is, some of the successes to date, and some of the learning. So now I'm going to pass over to colleague Jenny, who's going to tell you a bit about her work, and then we're able to take questions at the end. Thank you.
Thanks, John. Just move the presentation on. So hopefully everybody can see that okay. Hi everybody, I'm Jenny. As John mentioned, I've been on secondment with Coventry HDRC since January, part-time from University of Warwick, and I've been supporting research particularly around health and homelessness in Coventry. So I wanted to share some of the findings from the secondment work that I've been involved in, as well as some reflections about the experience of being on the secondment itself, and sort of thinking about culture change as the focus for today. So our starting point for this was really recognition that people experiencing homelessness have some of the poorest health outcomes and worst health inequalities in the UK. And there's growing awareness of the relationship between health and homelessness, and that homelessness is both a cause and consequence of ill health. And we know that life expectancy for people who rough sleep, so those at the very extreme sort of severe end of homelessness, is only 45 for men and 43 for women. So it's hugely below the national average for the population. And people who experience homelessness experience risk factors for poor health. So factors such as poverty, extreme poverty, exposure to violence, complex trauma, self-neglect, and so on, as well as greater risk of communicable diseases, and obviously managing health conditions is much more challenging for somebody who is homeless. And additionally, then difficulties accessing primary healthcare and preventative services mean that urgent and acute care services tend to be very, very highly used by people experiencing homelessness, and creates a lot of pressure itself. So reducing the impact of homelessness is a key Marmot priority and was a key focus for Coventry. And just to give you a quick picture of homelessness in Coventry and the sort of scale of the challenge for the city. So in the 6 months prior to September, the Rough Sleeper service found over 170 unique individuals rough sleeping in Coventry. So the Rough Sleeper service is a team that will go out early every morning around maybe 6 a.m. To try and identify and support people who are rough sleeping in the city. On average, 167 households approach the council as homeless each week. About 75% of those are single adults, 25% are families. And reasons for homelessness are very complex, but some of the common reasons that the housing service hear from people are things like the end of their private rented sector tenancy, domestic abuse, relationship breakdown, family exclusions, and so on. In Coventry, there are currently 1,278 households in temporary accommodation, and last year there were 890 social housing properties that became available in the city. But currently there are over 10,000 people on the wait list. So yeah, it just gives a sense of the issue of the fact that I think homelessness is rising nationally as well. So this isn't just a local issue, but nationally. And there are over 600 supported accommodation beds for single people recovering from homelessness. So that was our starting point, as I say. And so what I've been doing so far is desktop research and collating what evidence is available nationally and locally regarding health and homelessness for analysis. Been talking to stakeholders in the health, housing, social care and voluntary community sectors who support people to understand what the key challenges are locally in terms of health and homelessness in Coventry, but also what the barriers and enablers are to improving the health of people experiencing homelessness. And also listen to the voices of people with lived experience. As John said, that engagement with people with lived experience and public voices has been a really important part of the HDRC's work. So we've managed to have 17 conversations with people who are currently homeless about what's important to them in terms of their health and what their experiences have been of using health and local support services. And then we recently held a workshop with our stakeholders and public voices to present the findings so far and work with them to agree and identify what we wanted our research priorities to be going forward. So our areas of research interest that we want to focus on, where we think evidence can have the most impact to help improve the health of people experiencing homelessness. So what we've learned so far, and I'll just give some headline findings in the interest of time, but we know that people who experience homelessness are very often hidden from national and local statistics, and public health data around this can be quite challenging. And that's because people are often hidden because they're dealing with their situation maybe informally, so staying with family or friends or sofa surfing, for example, but also because of the transient and sort of unsettled nature of homeless lives kind of intrinsically. The data that we have within Coventry, the housing service is helpful, but it only tells us about the scope of demand for the service, not need, and particularly unmet need. Because that data, that information is only collected when somebody makes an approach to the council for support. So if somebody doesn't make an approach to the council, it's not recorded. And there's been improvements locally in recording housing information and people's housing status within health data. So by our local hospital trust, for example, and a specialist primary care service that we have in Coventry, which supports people experiencing homelessness. So there's been some improvements around the visibility of people experiencing homelessness within our health services data. But that data is held separately by the local hospital trust, for example, by the primary care services. So that's not joined up. So altogether, that means that our local population level data about people experiencing homelessness is limited. And we're thinking about how to improve that part of our work. Also, another challenge around doing research on this is that asking for information from people who are experiencing homelessness about their health, particularly during first encounters or contacts with people, can be quite challenging and not necessarily always appropriate. People can have other priorities, and there's a need to kind of establish trust with people. And training might need to be carried out as well to ensure that kind of questions and research techniques, information gathering is kind of appropriate and handled well to avoid causing people to further mistrust in services, which can make people want to, disengage in the future, which obviously want to avoid. And also conventional research methods that we have can be quite hard for people experiencing homelessness to engage with. And there's a need generally for more sort of innovative and flexible and inclusive methods. So I think there's a question for us as researchers about how can we undertake research with people experiencing homelessness in a way that's enriching for them and avoids further marginalisation. So some of the challenges then that the stakeholders talked about in terms of challenges to improving the health of people experiencing homelessness in Coventry included things like availability and access to specialist mental health support. So there is a specialist mental health team, for example, but it's a small team and there's capacity issues. And within general mental health services, there isn't always the extent of understanding and management around things like dual diagnosis, for example, for somebody experiencing homelessness. Access to flexible GP primary care services was another barrier. So there is a specialist primary care service in Coventry at the moment for people experiencing homelessness, which can offer things like flexible appointments and has trained staff. But that's just one sort of service, and there's a need generally for all primary care services to be more accessible for people experiencing homelessness. And then also access to dental services and poor oral health was another challenge. In terms of hospital and acute care, as I mentioned, so A&E and urgent care services tend to be very highly used. But the long wait times and sort of intense or stressful nature of A&E, for example, can be quite difficult for people experiencing homelessness. There sort of generally tends to be a bit more lower tolerance for, the wait times, particularly if people are, for example, struggling with addiction issues and things like that. So there is a dedicated pathways lead now in our local hospital to support people who are homeless with admissions, with their inpatient stays and with their discharge. But there's still these wider barriers for people experiencing homelessness. And then in terms of public health, TB has been a challenge in Coventry. So people experiencing homelessness, for example, struggle with the treatment programme because it can be quite intense, as I'm sure you know, as public health professionals. There's been some work developing outreach and awareness raising, but that's still a challenge at the moment. And then also another factor that stakeholders talked about were wider national policies that might hamper their efforts to improve access for people experiencing homelessness because of things like wider resource pressures and so on. So things that stakeholders felt would enable or be facilitators for improving people's health were a need for trauma-informed care and better understanding of what it means to be trauma-informed, a need for multidisciplinary working, building on some examples of good practice that we already have, such as our local palliative care team who work in a very outreach sort of trauma-informed way and are very good at linking in with other services, for example. The need to identify opportunities for earlier intervention and prevention, and then improving data so that we have a better understanding of needs and outcomes, and particularly thinking about how we can join up data across the system. And then we also talked to people with lived experience in terms of what they liked about current services. And I just wanted to share some of the thoughts that they gave around this. So people were very pleased to have kind of things like outreach support for certain types of treatment. They appreciated support to actually attend appointments as well from their individual support workers, for example. And generally people expressed how grateful they were and happy to know that there was help available when they sought it out. And I've included some quotes there of some of the things that people said. What people didn't like or found challenging about current services were things like the fact that everything was online, or a lot of things were online. So for people experiencing homelessness without internet access or smartphones, for example, that was a barrier. As I mentioned, long waiting times to be seen because it increased people's anxiety and gave people sort of too much time to think about things. And also for some people made them feel unimportant and sort of fed into a wider experience of feeling quite invisible. And some people were also quite reluctant to go to hospital because of previous bad experiences. So feeling a loss of control or feeling that they weren't treated very well or were misunderstood by staff. I'll move on to the next one just in the interest of time. And then what people told us would help them were things like more mental health support. So currently people felt they didn't get enough help with their mental health, which made them feel like they wanted to use substances, to feel more listened to by staff when they did access services, but also more generally by other people in their lives and other support services. Help with managing and keeping appointments, and also easier access to information about wider activities or services or clubs that might help people feel better generally in their lives as well, and opportunities to connect with other people who are not experiencing homelessness and who weren't experiencing drug or alcohol problems. People said that actually made it harder for them. So that's what we sort of learned over the last months through the work, and we presented that at a workshop recently. And through group discussion and then consecutive rounds of voting, we wanted to try and identify where we thought our future work should focus in terms of where the evidence could make the most impact to improve health of people experiencing homelessness. So following that process, we had three kind of key priorities or areas of research interest, which we're now focusing on going forward. And that was the impact of multidisciplinary and partnership working, prevention and early intervention, and then how evidence and data sharing can be improved to support strategy and service development. So, as I say, we're now taking those areas forward and, for example, establishing a working group comprising people from within the council, sort of performance analysts, public health analysts, and some colleagues from our local NHS partners to think about how we can improve the population level data and sort of address some of those data sharing issues. And we're also learning with other HDRCs about what they're doing around that too. We're reviewing evidence around prevention and early intervention, and we're hoping to do some evaluation work of a new multidisciplinary team to support people with complex health needs who are homeless. And then, as John mentioned, we're also continuing as part of this to think about how we can continue to best involve people with lived experience in the work. And just in the final few minutes, I just wanted to share some reflections then on the secondment experience itself. So thinking about the topic for today, which is culture change, and how the secondment has sort of contributed to that. I'm one of two secondees for the council, and so some things that we're starting to think about is, so why a secondment and what's unique about a secondment as opposed to other types of roles. So John mentioned things like the research champions and so on. So what is it about a secondment specifically? And so I think some of the benefits of that are the really in-depth exposure to that environment and those issues, and that sort of practice, the knowledge about practice. Also being seen as a colleague or peer, sort of rather than an outsider, perhaps, and that sort of access and legitimacy and credibility. And then I think the huge value of secondments as well, both for the secondee and the host organisation in terms of growing networks. And so thinking about for the future, you know, pathways to impact for research and collaborations and so on. But also, as I say, growing a knowledge of practice or research issues respectively, and the environments and the processes kind of involved. The different skills we've been able to develop in terms of communication, stakeholder management, and kind of managing different stakeholders with different interests as well. New technical knowledge and skills around particular processes, or, you know, even things like different kind of software and data that's been used, and project management skills as well. And I think the big one is really new ways of thinking and approaching issues and problems. So being able to see an issue in a different perspective, from a practitioner's perspective to a researcher's perspective. But despite those benefits, I think there's some important learning as well about the secondment process itself, and the time needed to, for example, build the relationship, as John mentioned at the beginning too, and understand the different ways of working. So I think there's a lot of kind of learning around that as well. Are we clear about our shared goals? So starting out, do we have the same understanding about what we're trying to achieve, and do we have realistic expectations about what can be achieved? How are we utilising opportunities to share knowledge and learning? So that's both internally and externally. So are we maximising opportunities for sort of upskilling and training and so on through the secondment? And also, I think sort of thinking about sustainability and legacy planning beyond the secondment as well. And there's also sort of practical issues and logistics to consider as well for the secondee and for the host. So managing two roles, for example, so, you know, 2 calendars, 2 emails, 2 line managers to some extent, making sure we're sort of able to coordinate meetings and things. And then also thinking about what time commitment for a secondment is appropriate and how can it be most effectively structured. So I've been 1 day a week, for example. So, you know, has that been the right approach? I think it's worked quite well, but that has come with its own challenges, you know, only being able to do it 1 day a week. And then just personal reflections as well, for me as a secondee, and for anybody that I suppose has held sort of dual roles. So thinking about what hat am I wearing? Am I wearing my researcher hat or my Coventry City Council hat, and does that change depending on the conversation and things? Imposter syndrome, you know, going into an environment, and I did used to work in a local authority before I went into academia, so it wasn't completely alien to me, but there's always learning to be had there. Thinking about how will this improve my academic career, you know, what opportunities for future collaboration might there be, or academic outputs? What impact will this have on my work-life balance and existing work commitments? And then how has the experience changed my perspective, both personally and professionally? And I think for me, that's probably been something really big to take away, is understanding homelessness and some of the complexity of the issues around it a lot more as well. So I will leave it there. Sorry, I've gone slightly over time, Chloe, but I'll hand over to you now. Thanks.
Thank you. So hi everyone, I'm Chloe. I'm a research fellow at Coventry HDRC. So I specialise in quantitative and mixed methods, and as Nicola said at the start, I'm also a trainee health psychologist. And today I'm going to be talking to you about creating the data catalogue that we've been doing at Coventry HDRC, and kind of a work in progress and the steps we have taken. So a bit of a quick overview of what I'll be covering. So I'll be introducing the data catalogue, talking through the process that we've undertaken to, I guess, create it, looking at the vision for the data catalogue as well. So kind of where do we want to take it? How do we envisage it working in practice? And also our next steps. So as I say, it is a work in progress. So kind of a short and sweet presentation to kind of end our session, but hopefully one that people will benefit from in terms of learning more about our catalogue. So the data catalogue is something that we've created at Coventry HDRC, and the aim of the data catalogue is to essentially provide a central place for individuals within the council, within our voluntary community and social enterprise organisations based in Coventry, and they'll be able to know what data is publicly accessible for research, for collaboration, for things like helping to support people with evidence-based decision making in policy, and basically just to help support individuals living in Coventry. So we're trying to really emphasise the importance of data and how that can be really used to kind of make the right decisions, especially when it comes to wider determinants of health and health inequalities. So far, as I said, it was a work in progress. We've drafted 6 topics. So we've drafted children's services covering early years and young people, so kind of ranging on that lifespan for children's ages, employment and skills, housing and homelessness, digital inclusion, and also air quality as well. So we've covered those so far. So a little bit about the process of developing the data catalogue. So the slide that hopefully you can all see, it shows the kind of key partners and collaborators whilst creating this data catalogue. So it's obviously ourselves, and we take the lead, and I take the lead kind of drafting it, trying to understand how it's going to look in practice. We have our Coventry City Council, so the co-lead for Pillar 1, Sanara. She is in continuous improvement and performance team, so she kind of helps to guide some of the topics, ensuring that the council's research priorities and ours, and also our kind of wider community, are all represented within the data catalogue. And we also have our university hospital as well, so as John mentioned at the start of the presentation. So the idea of the data catalogue was initially generated by the Pillar 1 co-lead, who is based at UHCW. So working collaboratively, Dr. Tim Robbins and I basically developed the structure of the data catalogue, and we used air quality as a pilot topic. So we wanted to make sure that when we were piloting the data catalogue, that it allowed for us to develop that kind of main structure for the catalogue and see how it would look for each topics, and also the benefits of presenting accessible data in this particular way. We knew that it was going to be a bit of a trial and error, but also wanting to make sure that people really benefited from the overall structure of the catalogue, which I'll touch upon in a couple of slides' time. So once we had done kind of the first couple of topics, so we did air quality first, followed by housing and homelessness, working with Jenny, and also we drafted digital inclusion as well. We then shared the data catalogue with the key teams within Coventry City Council, and that really helped us to feed our work into the data strategy, which was currently being written at the council as well. This enabled us to ensure that the data catalogue was aligned with Coventry City Council priorities, the new data strategy, and really trying to emphasise that kind of bringing together of ourselves at Coventry HDRC, Coventry City Council and UHCW. It was really nice to bring that kind of collaborative approach together. So some of the key platforms that are accessible that we've included in the data catalogue are mentioned on the slide, but include LG Inform, Plumplot, Nomis, Shapeplace. Coventry City Council themselves on their own website have quite a lot of data, so we wanted to ensure that that was really emphasised in there, and things like fingertips as well. There are also other kind of topic specific platforms such as DEFRA, West Midlands Air, for example, that would come into things like air quality that isn't kind of within every single topic that we've drafted so far. So when thinking about kind of the data catalogue, what we wanted to ensure is that we really touched on research governance at the beginning of the catalogue, because obviously we're trying to encourage people within the council and voluntary sectors to encourage kind of incomplete research, to use data within decision makings, for example. So we want to make sure that they are considering the research governance process. So it's really important and crucial to consider ethics and ensure that research considers that overall integrity, safeguards participants, and just generally has really good practice, because overall we want to make sure that data is being used correctly. So what we did within this section of the data catalogue is we referred to our own Coventry HDRC research governance and the framework, which ensures that all of the research activities that people do and when they use accessible data is done ethically, responsibly, and in accordance with any regulations and legislation, especially around data and data sharing. So what we try to do is ensure that the research governance policy is the fundamental to the framework and also really emphasised within our data catalogue. So the policy encompasses the research activity of Coventry City Council staff and also research that's done on council's behalf by outside agencies that are linked to the wider determinants of health. So we wanted to make sure that obviously all the data that is being used potentially and that we are signposting to is being used correctly. So the structure of the data catalogue is the same throughout all key topics, and we wanted to do this to try and create that sense of familiarity so people know what to expect for each of the topics, and also wanted to ensure that we got the right information across to the audiences when they do read the data catalogue. So it includes a range of topics and obviously the work that's currently being completed at Coventry City Council. So each of the topics includes a kind of set structure, including the definition of the topic being explored. So we're aware that in reality, some people may just want to know a little bit more about the topic, which is why they're looking for data on it. So we wanted to include a definition that was supported by evidence and literature when we were kind of introducing the topic in the catalogue. We provided some key literature links as well, so existing evidence that's already out there on the topic, so that may link to kind of any key national policies that are already in place, something that people may need to take a note of. It may link to existing research already conducted that's published, for example, just trying to emphasise that evidence is important in whichever format, whether that be the data that we're presenting in the catalogue or other existing evidence. We also provide obviously the data sources, which are publicly accessible, and we provide the links as well. So we wanted to make sure it was as accessible as possible. And by doing that, we provided the links, a definition of kind of how to use the data sources as well, and also how to interpret the data sources. So for some topics such as air quality, it was important to kind of make a bit of a caveat to some of the data, that it may not always be reliable or may not always to take it at face value, for instance, because sometimes there may be difficulties in kind of the reliability of the measures, for example, or for instance, we had quite a few in the children's services section where data was missing due to COVID. So we wanted to ensure that people knew exactly what was available in the data and also how to use it, just for clear transparency. And to encourage that collaborative working, we also have included in each section a key contact from Coventry City Council with permission obviously already granted from that particular person or that particular team. So if individuals using the data catalogue have any questions that are topic specific, they can go straight to that person within the council, and it immediately opens doors for communication and also for that collaborative working. So really trying to embed data as that kind of core start to that collaborative working going forward. So as I mentioned at the beginning of this presentation, that it is very much a work in progress, and we are trying to think about the next steps for this data catalogue. So obviously collaboration will be essential for the future of the data catalogue. So we will be working with Coventry City Council, the JSNA team that currently sit in the council as well under public health team, the Marmot team, and continuing to work with UHCW as well. We also, for the future of the data catalogue, want to bring in VCSEs a lot more. So looking at the voluntary sector in a lot more depth and kind of understanding what their priorities are and what they would like to be covered in the catalogue, what would be helpful for them, for instance, for future topics. So we really want to have that collaborative approach on the ground as well, and not just with Coventry City Council. Obviously, we'll continue to draft more topics and trying to figure out the structure of that going forward, and trying to see, is this accessible? Are we hitting the right audience? Are we making sure that in reality it's as clear as possible? We'll then officially launch it. So it'll go sit on our website, and that's where it'll kind of be for people to access. So we'll make sure that it's on our website and it's signposted clearly and promoted clearly as well for everyone to look for. And also through the Marmot Partnership website as well. So they will present it and provide a link to the data catalogue within their own website and work. And then finally, we'll continue to obviously promote and continue, and hopefully this will be a nice rolling process where more topics are added in time, and it really provides that kind of one-stop shop for accessible data sources for topics and that initial conversation, which then hopefully will lead to evidence-based decision making and that collaborative working in the future. So that was a very short and sweet introduction to the data catalogue, and thank you. I think that's now the end of our presentation. So Any questions?
Maybe while people are having a think, Chloe, I've got a question for you. It's around people being able to use the data and maybe some training that they might need in terms of understanding how to interpret it and apply it. Have you got any thoughts on how you're going to do that?
So within the data catalogue itself, there's quite a step-by-step of how to use the data sources, and because it's publicly accessible, most of the data is already transformed, so it's normally in a graph that's visually accessible, or it's in a clear table. So it's not something that we've, I guess, considered just at the moment, but it is very much a work in progress. We do offer obviously training within our HDRC under Pillar 2, so definitely will be something to consider for the future, especially if we look at more kind of council-led data that isn't already transformed and isn't already visually accessible, for instance.
Thank you. So we've got one question that's coming to the, there we go, we've got a hand up as well. So Elizabeth, do you want to come in and ask your question?
Hi there, thanks. That was a really interesting webinar. I've really enjoyed it. I've got a couple of quick questions for Jenny. Thinking about what you did in terms of accessing the hidden populations, what sort of tools did you use for looking for them? And what research methodologies did you find the most successful when you got hold of the populations for finding the data you needed?
Yeah, thanks, Elizabeth. So it's a work in progress, is the first thing to say. There's a range of sort of data sources that we've been looking at. So as I said, there's obviously data from the housing service itself, which is recording people who are approaching the council for support. So that's I've been working with the performance analyst within the housing team to look at that and try and understand what health information is currently collected within that data from people, because sometimes some limited, I would say, information about health is collected because it helps the housing service make an assessment of somebody's need and like a priority for housing in terms of urgency. But the data itself that the housing service collects about health in that sense isn't very standardized, and so it's quite limited at the moment from a research perspective as to what we can do with that. But there is some useful information there, and we're kind of working through that. And then alongside our partners with UHCW, which is University Hospitals Coventry, Warwickshire, which is our local hospital trust, and then the Anchor Centre, which is the specialist primary care service. We're starting to look at how we can share that data. Obviously, there's kind of data governance issues around that as well, which we need to look at. But then also there is nationally things like the phenotypes as well that we're starting to look at. University College London, UCL, have done some work around this as well, and also linking in with the other HDRCs. So there's a subgroup which is actually looking at this issue, particularly in terms of sort of homelessness and housing more generally. So yeah, we're at the beginning of a journey, I would say. So I don't have a sort of perfect answer for you in that sense, but yeah, it's a case of sort of having to look across what's available both locally and then nationally to try and understand yeah, the population at the moment.
Thank you.
I don't know if we want to address a couple of the questions in the chat as well. Joanna has asked, in a wider sense, how have you found changing the culture from the usual local authority top-down political and hierarchical-led approach to an evidence-led / lived experience approach to policy making and service planning? And this is something I'm sure a lot of other people are finding challenging. Do you want to take that one, John?
Yeah, I'll have a crack here. I did a bit of a response in the chat, so I'll respond in that way. Yeah. So yeah, I don't think it's easy, and it sort of depends where the organisation is that you're based in, and how much that organisation is based on it. So yeah, Professor Graham Curry from Warwick Uni, who's sort of our lead for that aspect of our HDRC, as I put in the chat, he describes defining culture in an organisation is like nailing jelly to a tree, i.e. it's like really hard to define exactly what it is and what you're trying to change. And I guess one of the challenges that we had was not well in the time between Coventry applied for the funding and got the funding, there was a change in chief executive and organisation. It was the previous chief exec who led the bid. So when that person left and the new one came in, obviously not knowing anything about it, it was a challenge to get them therefore engaged on it. So I think all the points that Joanna's talked about are valid, and I think it's very much about taking people along with you, like I talked about, thinking about change management, and also really demonstrating. So a lot of the asks from our leadership board in the local authority are, you know, what difference is it making? How is it adding value? What's the impact? So our funders, NIHR, are very focused on what they call routes to impact. So we try and demonstrate and always think about, you know, what's the impact going to be of what we are doing, including the examples that Jenny and Chloe have gave. And one of our key interventions is our research ambassador intervention. And just going, I'll just briefly do two in one. So what Charlotte's asked about, some of the functions for research ambassadors. So that's very much about people within a particular area of the council who are interested in research as they're personally interested. So it is a development opportunity for them as individuals, but what they're asked to do is really champion evidence-based practice, use of academic research around other forms of knowledge within their part of the council, their team, their service area, and they have to have influence in that respect. And operationally, they do it in our model as a casual contract. So they do it on top of their day job, but there's other ways that can be done. And we sort of look at that for the council employed ones. We're looking at it over a 3-year cycle. So in year one, it was very much them getting up to speed, understanding, making the context, making the relationships. And then we've had 3 that have done it for a year, and those that are going into year 2, it's then around them really starting to do the sort of things a bit like what Jenny's spoke about, but from the perspective of someone employed within the council. So working with researchers to you know, start to identify and answer areas of research interest, and so therefore they're ambassadors of the HDRC. So that's why we chose the name. They are, by them doing it and being engaged from within their service, they are there to, if it works, they're the change agents, you know, within their teams, within the council. So we aim to have around 10 of them at once. We've got 4 at the moment. We're doing a round of recruitment at the moment, and we've just recruited 8 in the voluntary sector in a slightly different model. Thanks.
And we're down to the last seconds, but if we can quickly do Gareth's question. If you want to come in, Gareth.
Yeah, I'll try and be quick. I was just wondering if you've had any success in changing council policies in light of some of the culture change, because some of the things we're facing as well are similar to yourselves, but we're sort of coming up against barriers for existing policies in the council. And I just wondered whether, if you've overcome anything and had any success in actually amending any existing policies you might have in place.
No, that's not something we've, I guess, attempted to do, but we have introduced a research governance guideline stroke policy. So yeah, no, but yeah, happy to. I know we do chat, Gareth, don't we, about things. So yeah, happy to chat offline about it. Yeah, thanks.
Well, thank you everybody from Coventry for the presentation. We're right on 3 o'clock now. So I know there is a point that Claire raised in the chat. We'll maybe see if we can get something in terms of an email or something like that out just to round that off. But thank you very much to John, Jenny and Chloe for presenting. And we'll see you all again for the next webinar. So final thanks to Coventry. Thanks everybody. Bye bye.
Thank you.